Hello, my name is Rachel Haswinkle, and today I will be discussing two different case files that both regard little babies. The first case involves a newborn who appears normal at birth. However, within 24 hours, the baby girl developed lethargy, hypothermia, and apnea. The attending physician suspects that the girl has some type of metabolic disorder, and lab work has been ordered. So there's four different diagnostic tests that could be run, and today I'll be discussing which one I think is the correct one and why the others wouldn't be a good fit for this type of diagnosis. So the different diagnostic tests include blood glucose, urinary acids, serum fatty acids, and plasma glutamine. One of these would be the optimal diagnostic to distinguish between urea cycle disorder and a disorder in the beta oxidation. Urea cycle defects are a result of deficiencies in enzymes required for protein degradation. In the urea cycle disorders, the nitrogen accumulates in the form of ammonia, resulting in hyperammonemia. For a beta oxidation disorder, either a transport defect of a fatty acid or a defect in an enzyme involved in the fatty acid oxidation pathway can cause fatty acid oxidation disorders. Patients with fatty acid oxidation disorders usually have features of hypoglycemia without ketosis during episodes of decreased carbohydrate intake. Given these diagnostic choices, I believe the plasma glutamine would be the best diagnostic tool to differentiate between urea cycle disorder and beta oxidation defects. Glutamine is a non-toxic and non-essential amino acid which takes part in the detoxification and transport of ammonia. In urea cycle disorders, plasma glutamine levels will be elevated. With glutamine, however, levels are normal in the beta oxidation defects, so this would be the right diagnostic tool to use for this little baby girl. So the other options are urinary acids would not be a good way to detect these two deficiencies because it is used to detect a specific type of urea cycle enzyme deficiency. Serum fatty acids are rarely used as a marker for beta oxidation disorders. A good marker for detecting a beta oxidation defect would be acylcarnitine. So again, those aren't the very good ones. The one that they want to use is the plasma glutamine test. From the blood work, I believe the proper diagnosis would be the ornithine transcarboxylase deficiency. Ornithine transcarboxylase deficiency is an X-linked deficiency inherited by and is a urea cycle disorder that is the most common. OTC is due to excess carbamoyl phosphate that is converted into orotic acid. This leads to an increase in urinary orotic acid excretion. Because the orotic acid is not being properly utilized, it must be eliminated. This disease's symptoms vary within sexes. Affected boys have high serum ammonia levels. However, affected girls with this disease-causing mutation usually develop hypoanemia, lethargy, apnea features, and these are all the same kind of symptoms that this little baby has experienced. So OTC is the right diagnosis for this little baby. So the next case involves two little babies, and this case has two babies that have the presumptive diagnosis of phenylketonuria, also known as PKU. So for these two little babies, a BH4 loading test was performed to see exactly the proper diagnosis for these two. So phenylketonuria is a metabolic defect that is due to the absence of the enzyme phenylene hydroxylase. Without this enzyme, the body is not able to metabolize the amino acid tyrosine from phenylalanine. Phenylalanine is an essential amino acid found in foods that contain protein. In the lack of this enzyme, phenylalanine levels accumulate in the body and can damage the central nervous system and cause brain damage because it is toxic to the brain. Phenylalanine cannot be metabolized by the body, hence it builds up in the brain, leading to symptoms such as failure to thrive, short stature, and mental retardation. The treatment of phenylketonuria consists of, by administering by the means of diet, the only quantity of phenylalanine that is needed for the growth and repair of tissues. So based on these two BH4 loading tests, we can kind of diagnose these babies and get their treatment started right away. So based on the results of the patient's test results, in patient A, the blood levels of phenylalanine had not decreased but actually increased. And in patient B, it decreased in the loading of BH4. So the patient B, the little baby B, has the BH4 deficiency, while patient A has the phenylalanine hydroxylase deficiency. And BH4, a little bit about that, is an essential coenzyme for the conversion reaction of phenylalanine to tyrosine. So it's carried out by the enzyme phenylalanine hydroxylase, whose activity is deficient in patients with the phenylketonuria. So that's why it increased in the patient A but decreased in the patient B. So yeah, those are my two cases about the two little babies.